On this week's Health Talk, we'll discuss the causes, the symptoms, and treatments for diverticulitis, a very common disorder. So stay tuned for some helpful information. Coming up next. Hi, I'm Dr. Eric Mazur. Today we're going to discuss diverticulosis and diverticulitis with Dr. Ryan Bendl. He's a colorectal surgeon from Western Connecticut Health Network. Welcome to Health Talk, and welcome to the Western Connecticut Health Network.
Thank you for having me.
Thank you for coming. So diverticulosis, very common disorder. I think people get diverticulosis and diverticulitis really messed up in their mind. Let's start with the one that doesn't need treatment. Diverticulosis, what is it?
So diverticulosis, you're right, is very common. Actually, at the age of 60, 50% of patients, of Americans have diverticulosis. And by the time you hit 80, by the age of 80, 2/3 of patients across the United States have diverticulosis. In 2010, it actually accounted for over 300,000 hospital admissions, in addition to 1.5 million outpatient visits. So you're right, it is a very common
disease. So this is common, but it's also something that costs some money in our healthcare system.
Yes. So when we're born, the colon is normally nice and smooth, and what diverticulosis is a condition in which we form outpouchings of the colon. Again, it happens in the majority of patients as we age. Most patients, again, aren't born with this, but this is something that's acquired over time.
The colon is the large bowel for people at home.
Yes.
And it usually has a small, actually it has some haustrations, some folds in it, but it doesn't have these little outpouchings. I don't know whether you remember them. You may be too young, but back when I was a kid, if you had the old tube tires, occasionally there'd be a little rupture out of that inner tube, and you'd see that, and that's sort of what's happening.
Yeah, that's a good way to describe it. It's like I said, like a little outpouching or a little pocket, and in some patients we describe it as a blowout of an inner tube.
Do we understand why this happens or what contributes to it?
Well, we're not really sure. Back in the 1900s, there were studies that were performed, and then they found that patients in Africa had a very low incidence of diverticulosis. When they compared that with people in Europe, they found that there was a much higher chance of patients having diverticulosis. So at that time, the theory was that it's directly related to the amount of fiber in one's diet. So therefore, if you have a low fiber diet, that you're more likely to develop diverticulosis. Now, we found that just because you eat a lot of fiber doesn't mean that you are not going to get diverticulosis, or that the diverticulosis is going to go away. Once you have it, you're stuck with it.
It's an anatomical change you're sort of stuck with.
Correct.
Which sort of makes sense. You know, have a background of physics and engineering, and it sort of makes sense that a colon that is this wide, sort of normal width, and is distended by a lot of fiber, produces lower pressures in the colon than one that is squeezing down hard on less residual. But it turns out that that's not the whole story. You just told me that today.
Yeah, like I said earlier, we used to think that it was because if someone is eating a low amount of fiber, they develop more pressure in the colon, and that's what's going to lead to these blowouts in the colon or these outpouchings. But again, the more that we know about this disease, we're finding out that that may not, in fact, be true. So
now we have a picture of what it looks like from the inside, which we'll bring up, so you can actually describe to us what these outpouchings look like.
Absolutely.
Well, it'll be up in a minute. But I was also taught that the outpouchings occur along the little arteries that penetrate. Is that still thought to be the case?
That's true. The areas where the small arteries penetrate the intestinal wall is usually the areas that are the weakest of the wall of the colon, and that's where these outpouchings form.
So tell us what we're looking at here.
Yeah, so this is an image from a colonoscopy, and most patients, like I said, are asymptomatic. Again, 2/3 of patients by the age of 80 will develop this condition. Now, this image here is a patient with severe diverticulosis or numerous outpouchings.
And we're seeing them from the inside.
And this is a view from the inside. Correct.
So like in the lower right-hand corner of the the image? Is that a hole into a diverticulum?
Correct, yeah, and these little false passageways or little pockets. Now, most patients are diagnosed at the time of colonoscopy. Most patients actually remain asymptomatic from this disease, although 10 to 15% of patients will go on to develop a condition known as diverticulitis.
And so diverticulitis is a symptomatic form of diverticulosis is just what happens to your colon as you get older.
Correct. So diverticulosis is the presence of these outpouchings, whereas diverticulitis means that you actually have an infection or inflammation of one of these diverticuli.
And before we get into the diverticulitis, how many of these outpouchings do you typically get, and where in the colon do they typically form?
They can form really anywhere. Patients of Asian ancestry tend to have them more on the right side, but more commonly in the United States, patients tend to have them in the sigmoid colon. And that's the last portion of the colon before, where most of this hard stool begins to form and be stored. And that, again, goes back to the thinking, like we mentioned earlier, that maybe this is the area where there is the most pressure, which is leading to these outpouchings.
Does that mean, do you recommend, or are colorectal surgeons and gastroenterologists recommending higher fiber in the diet sort of your whole life in order to help prevent this?
Absolutely. We do recommend patients to have a high fiber diet. Now that includes fruits and vegetables and bran, those sorts of things. Now it's very hard for us to actually get the amount of fiber that we need, and we do recommend to a lot of patients that they take an over-the-counter fiber supplement, and that's typically in the form of psyllium fiber, and that's a natural fiber. Again, it's over the counter. There's multiple brand or store names that you can purchase.
Metamucil is one, I guess.
Yeah, that's one of the yeah, exactly.
Not to just pick them up, but I think they're one that people may be familiar with.
Yeah, that's the most common one, but there's a variety of different like I said, fiber supplements out there. There are other synthetic fibers, and some people, when they're starting on a fiber supplement, if they haven't been on one in the past, they may find that initially they're a little gassy or they have some abdominal discomfort. That should improve with time. And if it doesn't improve with the natural plant fibers, we can consider switching them over to a synthetic fiber.
Right. Are you recommending this for virtually everybody, or just after somebody is diagnosed with diverticulosis, or even just after they've actually had inflammation, which we'll talk about?
Well, yeah. It's hard to really know whether starting fiber early in life is going to prevent it. Again, we're not 100% sure. Some of the epidemiologic studies seem to suggest that. But we don't really know if starting it early is going to prevent them from ever forming. It's definitely safe in any patient. It will definitely help with the daily bowel function, and definitely in a patient that we know has diverticulosis, we will encourage them to eat this.
Can people look at their bowel movements and have some sense of their risk? I think of the small pebbles that some people have because of the hypermotility of the gut, or people that have sort of bulky, soft movements. Are the tiny little ones higher risk for diverticulosis?
Yeah, not necessarily. Everyone's bowel movements are different. The frequency, the timing. Some people, go once a day. Some people go multiple times a day. Other people don't go every day. So it really varies from person to person, and not one person is more at risk than another for developing this. The one thing that we do know, and actually part of the reason why I became a colorectal surgeon, is diverticulitis or diverticulosis tends to run in families. So me, for instance, my family, my father and all of his siblings, he has 3 siblings, they all had diverticulitis. My grandmother, their mother had diverticulitis. So we are seeing that although there doesn't seem to be any gene or anything like that related to the formation of diverticulosis, it does tend to run in families, and we will sometimes see that siblings or parents.
That's really interesting, that because there are these collagen things that can run in families that are not particularly well defined. I wonder whether we will eventually find a gene that explains that. So once is there any reason to screen someone for diverticulosis? finding it early, and I think you mentioned we find most of these on colonoscopy, but I presume that's from cancer screening, isn't it?
Correct. Yeah, and there's no real indication or there's no real reason to screen just to look for diverticulosis. Again, if you have symptoms of it, or if you have an attack of diverticulitis, then those are the patients that we would recommend have a colonoscopy. So it's actually recommended that anyone that has an episode of diverticulitis 6 to 8 weeks after they've gotten better, and we could talk about treatment in a second, but those patients are indicated to have a colonoscopy. Now, like you alluded to earlier, colon cancer screening, everyone by the age of 50 should have a colonoscopy. Now, that's with the caveat that if you have a family history or other symptoms, you may have to actually have it earlier. But yes, there's no real need to go look for it unless you have symptoms of it.
And maybe we should talk a little bit. What are the symptoms of these are, again, benign. We should point out, again, outpouchings of the colon wall. They have little holes that go from the colon. They don't leak, they shouldn't leak asymptomatically. And they really, do they affect the function of the bowel if they're there just there
again,
regularly?
If the symptoms, symptoms of diverticulitis may or may not, diverticulitis does have symptoms. That's the infection. So those are the patients that we expect usually have pain, and the pain is oftentimes in the left lower quadrant. They could present with fevers, depending on the extent of the infection that they have. Some people actually can develop a hole within the colon, and that can become a surgical or medical emergency where you would have to be seen in the hospital. Those patients, if there's a suspicion of diverticulitis or you think that you have an infection, you definitely should see your medical provider, and your doctor may want to get a CAT scan, may send you to the emergency room to have blood work performed as well.
Now, diverticulitis can bleed as well, can't they?
Yes, they can. Again, we talked about earlier that these diverticulosis, these outpouchings typically form where the blood vessels penetrate the intestinal wall or the colon wall, and because of that, they're prone to bleeding. So it's actually the most common cause of a massive bleed from the colon in adults is secondary to the diverticulosis.
So again, just for the folks at home, and so they're very clear on the language, diverticulosis is the formation of these diverticulae in the colon.
Correct.
Diverticulitis is an inflammation of one or more of these outpouchings.
Correct.
Is that right?
Correct.
Okay. So let's start with the bleeding diverticuli. And I know it can be quite substantial. How do you figure out which one is bleeding? You go in there, you've got blood all over the place.
Yeah.
How do you end up just resecting a large part of the colon? I know there's some arterial techniques.
Yeah.
Let's talk about that.
So it depends. If a patient's having a significant amount of bleeding, those are the patients that usually will come to the hospital. They're having, multiple bloody bowel movements, and if that's happening, you definitely should call 911 and be seen, in the emergency department immediately. Those patients are typically admitted to the hospital, and you're right, there are some techniques where we can inject, a dye essentially through the arterial system, and we can actually see that dye leaking out into the intestine. Now, due to advances in various techniques, we could actually stop the bleeding without surgery. And surgery is now reserved for those patients that only fail those techniques. But a lot of people with blood transfusion or interventional radiology, which is when they go in through the artery.
So sometimes it'll stop on its own and you'll be okay. Other times, using the arterial catheter, you can put a little clot in the artery and stop the bleeding.
Exactly.
And yet not compromise the viability of the bowel.
Yeah, so 30 years ago, surgery for bleeding diverticulosis was much more common. Nowadays, we don't see it as often.
Yeah, I remember in my early days, they would do a hemicolectomy on some of these patients.
So
take half the whole colon out.
And actually, in some patients where the bleeding is so extensive and we can't find it where the bleeding's coming from in a life or death emergency, those patients actually would have their whole colon removed, and you could live perfectly fine without the colon. But again, this is a rare complication, but it is a complication of diverticulosis and having these outpouchings.
And we have to take a break right now, but what I'd like to do is when we come back, discuss diverticulitis, which is the inflammation of these diverticuli. That is the much more common manifestation, and I think something a lot of folks may have had. So we'll take a short break and be back to discuss the common entity of diverticulitis. Hi, we're back with Dr. Ryan Bendl. We're talking about the colon, a very common thing, important to all of us, and the entity of diverticulosis and the entities of diverticulosis and diverticulitis. Okay, so I think we've talked about the diverticulosis and that they can bleed or have nothing. Tell us about how diverticulitis occurs. It's really a pretty simple mechanical issue, isn't it?
Yeah. So what happens is these outpouchings, again, the diverticulosis, for some reason or another, there's a blockage of one of those outpouchings, and in consequence to that, there's actually a rupture or an infection of that outpouching or what we call diverticulitis, and that's how it forms.
And the symptoms of that?
The symptoms, again, typically are patients will complain of left lower quadrant abdominal pain. They could also present with fevers, a change in their bowel habits. A lot of the patients that have this condition, they'll lose their appetite. They won't want to eat. They'll kind of just feel blah. And again, if you're experiencing tender in the left lower quadrant, typically, but those patients should be evaluated by their healthcare provider.
It's really sort of interesting. The colon, as we know, is just filled with bacteria and germs, and somehow, as long as they keep flowing out, we're okay. But if you clog off a small portion of that, it's like anything, I guess, any orifice of our body that gets clogged off, our sinuses, our gallbladder, our diverticulum, they get infected.
People used to be told for a long time, actually up until the last couple of years, that if you have diverticulosis, you should avoid eating things like seeds and nuts.
That's just what I was taught.
And with
the thought that those seeds are going to block up those the orifice.
And like I mentioned earlier, I myself have a strong family history of diverticulosis, and my family would avoid eating all these things. But we've actually come to find out over the last couple of years that that's in fact the opposite. And patients that have seeds, have nuts, you're actually less likely to develop diverticulitis.
Is that because of the fiber?
Exactly, and that all goes back to fiber, like we were talking about earlier, and encouraging patients to have a lot of fiber. Because patients that tend to avoid seeds and nuts and all those things they're avoiding fiber in effect.
It's so interesting because until the last 20, 30 years, so much of medicine was based on anecdote and what seemed like common sense. And I think that was the common sense, or somebody would have a seeded fruit and they'd get diverticulitis, and the doctor would say, sure, I know what caused that. And then it turns out when you actually study these things, it's different. So that is a relatively new recommendation, which is to keep up your nuts and seeds and fruit ingestion. Now, diverticulitis can range in its severity from relatively mild, a little bit inconvenient, all the way up to a surgical emergency.
Absolutely.
Tell us a little bit about when does someone, do they always, if you have abdominal pain, have a history of diverticulitis, should you always see the doctor? And then what precipitates some of these more serious considerations?
Well, patients with diverticulosis, only 10 to 15% of those patients will actually ever have an episode of diverticulitis. So even though it's very common to have diverticulosis, and the majority of people out there do have diverticulosis, it's really the minority that goes on to develop diverticulitis. And you're right, the infection or the diverticulitis can vary significantly from something that was very mild that's treated with over-the-counter antibiotics and diet modification. So again, we've been pushing fiber a lot, but when someone has an episode of diverticulitis, when they have the infection, we actually want to give the colon a rest. We want to give it some time to heal. So we actually, for a period of roughly 2 weeks or so, we'll have patients go on a low-fiber diet. So we say, avoid all the healthy foods, the fruits and raw vegetables.
That's
and
what I
bran
have been eating in the last 10 years.
We avoid those things just for a short period of time before we go back and let the diverticulitis.
So what is in a low-fiber diet?
Yeah, so
what are we talking about?
Like anything from rice, potatoes, any sort. Milk is fine. So chicken, fish, beef, all those sorts of pasta is totally fine as well.
So a lot of what we want to avoid are the vegetables that have a lot of cellulose.
Exactly.
And you'd obviously stop taking your Metamucil pills or your during that. So you give them all a rest. And you give it the antibiotics. So you should see the doc if you're having pain, low-grade fever like that, maybe a gastroenteritis, but may be diverticulitis. How do you tell those two apart clinically?
You know, it is hard sometimes to tell the two apart, and that's sometimes why we'll send patients to have an imaging study or a CAT scan. Now, this disease since it is so common, it's managed very well by primary care physicians. You don't necessarily have to go see a colon and rectal surgeon or a gastroenterologist if you're having, you know, abdominal pain, especially if this is the first episode. You know, patients usually come to us after they've had repeated attacks. We talked a little bit earlier about, you know, the spectrum of disease. So you're right. Most people will get better with antibiotics alone. And even, you know, of the small subset of patients that do get diverticulitis or do get the infection, even smaller percent of those patients will have a complication where they'll have a perforation or an abscess.
And then the perforation being that little
where
pouch
rupture
breaks through, and so the infected material gets out into the abdominal cavity.
Yeah.
It tends to form an abscess, though, rather than a full peritonitis, doesn't it?
Yeah. So more commonly, patients, if their body's able to localize the infection and form a little collection, we can actually nowadays, you'd have to be admitted to the hospital, but that could be drained by a radiologist, and we can treat you with IV antibiotics. You know, if the perforation is so large that the stool from inside the colon is now going into the abdomen, those are the circumstances where it's a medical emergency, and patients would need surgery immediately. Now, the surgical treatment of this disease, if you have the infection, if it's an emergency, unfortunately, we have to resect the area where the hole is, but it's because of all the inflammation, it's too high risk to put the intestine back together.
Okay.
So that's the circumstance where people will...
And explain that to people.
Yeah.
Why is it high risk in the setting of inflammation?
Yeah, because if we try to connect a colon that's infected or diseased or inflamed, the risk of that connection falling apart and you needing an additional surgery a couple days after the initial is actually very high. So those are the patients where they get what we call a colostomy bag, or that's where we bring the intestine or the colon to the abdominal wall, and the stool will actually drain into a bag. We do that as a temporary means to get the infection under control, and then we plan to go back in a few months and connect the intestine back together when the infection is resolved.
So you're not stuck permanently
Yeah,
with
so
the
this isn't a
colonoscopy.
permanent, but this is something that we see not too often, but fairly regularly, especially in this part of the country. It's fairly common.
Someone may ask, you've got these little outpoachings, you know they're there. Why not go in there and just close them all off?
Yeah, I mean, unfortunately, that would be great if we could, but they could always form in other places, and also even if we do the surgery. So some patients, there's two reasons why people have surgery. One, which we just talked about, where you have a big perforation and you need emergency surgery, or you're not getting better from intense medical treatment in the hospital. The other group of patients are those that recover from an episode of diverticulitis, or they've had repeated episodes of diverticulitis, and they say, you know what, I've just had enough. This is, I'm losing days of work. I want to get back to the quality of life that I'm used to enjoying. So those are the patients that electively have surgery.
So that actually, I think that answers the question that I had. If someone's had an episode, are they more likely to have then a second episode?
Absolutely.
So there seems to be some predisposition.
And the more episodes that you have, the more likely that you are to have another episode. Fortunately, usually the first episode is the worst episode. So if you've had a mild attack, if you do have another attack in the future, it's typically going to present like the first one. But you're right, the recurrence rate, the worse the attack, the higher it is. The higher the chance of you having a repeated episode.
And certainly the severity or the risk depends in part upon the prior health of the patient. And I can think of a patient that I was caring for who had an evolving leukemia and was really stable until he came in with diverticulitis.
Yeah.
And he ended up dying of the disease because he had no white cells to fight it.
Yeah.
So that's not a common infection you see in the setting of leukemia,
Yeah.
but it can be serious if your immune system can't handle it.
Correct. So patients with chronic renal failure, or like you said, someone that's chronically immunosuppressed, those are the patients that actually are at the highest risk of coming in with bad disease or a bad perforation. And if they've had a mild attack, we'll usually recommend that those patients undergo an elective resection, or electively, when things are calm, we go in and remove that portion of the colon that was infected. Now,
so you don't remove the whole colon
No,
with diverticulitis, but just the area
correct,
that's
yeah.
been involved.
And typically patients' bowel function will return to normal after the resection. I do tell or warn patients that even after resection, there is a risk of you developing recurrent diverticulitis in the future. It's about 6%, which is pretty low, but it's not zero, which would be ideal, obviously. And most of the surgery nowadays we're able to do minimally invasive. So whether it's through laparoscopy, which is where we use a camera and small little holes in the abdominal wall, or something that we use now called robotic surgery, again, which consists of small incisions in the abdominal wall. It's a lot easier in terms of recovery. People are usually in and out of the hospital if they undergo the surgery within a couple of days.
Yeah, we have, I think, about 15 seconds left, but I had my gallbladder removed laparoscopically about 5 years ago, and it's really amazing how simple the procedures are. I do remember the old days of gallbladder surgery where you got a big scar under the liver, and patients were in bed for a week and out of work for a month.
Yeah, definitely recovery, return to work, post-operative pain is all much better than what it used to be.
So if you do need this surgery, there's certainly in most instances opportunity. But let me ask, again, just with just a few seconds left, I know having inflammation and scarring in the abdomen limits your ability to do some sorts of laparoscopic and robotic surgery. Do you find that that's the case with prior episodes of diverticulitis, or are you able just to go around the whole
we're
mess?
usually able, truth be told, like I said, this is a very common disease, and we're so used to dealing with disease. I mean, it can be complicated by the inflammation forming tracts to other organs in the area, so it can become very difficult to manage surgically. And in those cases, if we have to, for safety reasons, make an incision to carefully dissect out the colon, we'll sometimes have to do that. But the robotic surgery now allows us to do a lot that we couldn't do with just a laparoscopy, so that's
well, it's good news. It's good to hear that there's so much that we do. It was a great discussion on a common disease. I appreciate it. When we come back, we'll have today's health question, and we'll keep Ryan on the set to help us answer it. Hi, this week's viewer question is, how can you prevent colorectal cancer? We have the ideal expert on the set with us. Okay, so how do you prevent it?
Yeah, the best way to prevent is colonoscopy. In addition to knowing your family history, which may put some patients at higher risk than others, colonoscopy is really revolutionized how we pick up and how we treat colorectal cancer.
Since we know almost all of them come from polyps, and we can catch the polyps years before they form cancers.
Correct, and even some small cancers can even be removed nowadays through a colonoscopy. So depending on the extent, or if it's an early colon cancer, that could actually be removed with a colonoscopy.
So colonoscopy is recommended to start at age 50? At
age 50, yes. If you have family history or inflammatory bowel disease, it would be indicated sooner depending on...
Yeah, and just to get, if you have I keep emphasizing this on this show, if you have a relative that has cancer, colon cancer at age 45, a brother or a sister or a parent, you should go 10 years before that,
Correct.
so 35.
Correct.
So you can start quite early in some of these situations.
Absolutely. And then other patients, if you have any alarming symptoms, so if change in your bowel habits, if you're having rectal bleeding, some people just think it's hemorrhoids, but really it warrants a thorough investigation.
It really has changed, and colon cancer is going down as a mortality. Anyway, we've run out of time. So if you have a question at home you'd like to ask on Health Talk, please contact me at healthtalk@oralhealth.org. I want to thank our guest today, Dr. Ryan Bendl, for coming on Health Talk and all the wonderful information.
Thank you.
We'll see you next week on Health Talk, and bye-bye. And get your